What is the objective scientific data on gender-affirming care, the interplay of sex and gender, and how can Christians lovingly and factually have conversations about this topic in our current culture and climate? I'm St. K. You're listening to the Foreign Saints podcast, keeping Christianity distinct in a world that always wants to water us down. And this is episode 3 of Transgenderism and the Gospel, a series dedicated to actually looking at what the Bible has to say about and towards this topic, looking at the scripture, looking at the science, and also hopefully equipping Christians to be able to have this conversation, and to any and all transgenders or people that are struggling with gender dysphoria that happen to watch anything in this series. I definitely hope this is an extension of an olive branch to you, and I'm just laying my cards out on the table. I definitely do hope and pray that all that see this would come to have life in the name of Jesus, would come to have life, eternal life, by knowing the Father and the Son whom He sent. But today's episode is all about the science, baby. All about the science. That's what we're getting into, all right? If you want the scripture, look at the previous 2 episodes and look at the episode or 2 after this one. But for this, we're talking science, all right? And before we can get into all of the studies and stuff that I want to talk about, we need to have a conversation about evidence-based medicine, all right? Evidence-based medicine. What is it? And, how do we let that guide our clinical decisions? All right, full disclosure, I am a licensed RRT, that's registered respiratory therapist with an associate's degree in applied science for respiratory therapy from Catawba Valley Community College. And for the next couple of months from this recording, my EMT license in the state of North Carolina is still active. So I am in that sense qualified to discuss the concept of evidence-based medicine. Now, that being said, I am not a doctor. It's true. I'm not a doctor in anything. So don't hear me like you're hearing a doctor. Capiche? I will be quoting many doctors and practitioners in this episode, but never basing anything on my own authority unless it crosses over into the realm of respiratory care, which most of this won't. There is a little section where I will talk about some respiratory concepts that are, I think, relevant, but for the most part, that won't be the case. Um, but I will, on occasion, share relevant stories from my own experience in practice as examples of a point that I'm making, but never as proof of a point that I'm making. It's an important distinction to understand. All right, now let's go ahead and get into it. I got my textbooks over here, and the first textbook, hang on. The first textbook I'm going to be opening up is this big boy right here, Egan's Fundamentals of Respiratory Care, the 10th edition, Chapter 2, Quality and Evidence-Based Respiratory Care. All right, and I do have that queued up already in a separate window so that you guys can see it. Hang on, it's not this one. Here we go. All right, now let me go ahead and open up my textbook to the same page. You see what I said there, pages 30, starting on page 36. Starting on page 36. Alrighty, so evidence-based medicine, as you can see up here in the top, evidence-based medicine refers refers to an approach to determining optimal clinical management based on several practices. Firstly, a rigorous and systematic review of available evidence. 2, a critical analysis of available evidence to determine what management conclusions are most sound and applicable. And 3, a disciplined approach to incorporating the literature with personal practice and experience. It can be thought of as understanding and using the best quality evidence available, the best designed, the most rigorous clinical trials that you have access to support the most appropriate and correct possible clinical decisions. All right. And we need to go through the different tiers of evidence-based medicine, the three main tiers of evidence-based medicine that we have. All right, as you can see on the screen here, our first level would be the single case report, the simplest and least rigorous design, the single case report, in which a new clinical issue or problem is described in a single patient. Okay, let me scroll down here. So what we have here, a new clinical issue or problem described in a single patient, useful for pointing out new insights or possibilities regarding a disease or treatment, but it does have its limits. You can't use a single case report to prove the effectiveness of a treatment or the causality of any one risk factor because of the lack of a control group to compare your case study with. Okay. Um, Next up in the hierarchy, getting used to this zooming thing that my mouse can do here, is the case series, where you've collected a group of patients with similar clinical features, a case series. And it may have greater impact in that it suggests that the issue, whatever issue you're looking at, is more general than in a single patient alone. However, similar to a single case report, a case series cannot prove the efficacy of a treatment or the causality of a risk factor because no comparison or control group is included. All right, why do I go through, why do I mention both of these things um, off the tip? Because of the fact that this conversation about gender affirming care is a question about what best practice is, not necessarily about what may or may not have worked, what may or may not have given a positive outcome in one or two or 10 uh, individual cases here and there, right? For something like that, you really are going to need the next piece of our chain of evidence-based medicine, the next one up, the cohort study, which compares the clinical outcomes in two compared groups, also known as cohorts. Let me move on to the next page here. So known as cohorts. Let me zoom in. And the strength with the cohort study, you got two broad types of study designs: observational cohort studies and randomized controlled trials. In trying to establish whether a treatment works, i.e., has efficacy, an observational cohort study would compare the outcomes between two groups of patients when the treatment was allocated to one group but not the other by either physician or patient choice, right? And then you even got a better version of that, the randomized controlled trial, the most popular kind, the most well known as well, I think, at the popular level, even if people don't always know what it means. Sometimes regarded as the most methodologically rigorous study design, when well conducted, would compare the outcomes of two similar groups of patients when the use of the example that the textbook is using is obviously a respiratory one, but you get the idea. The randomized controlled trial is comparing the outcomes of two similar groups of patients. All right. Um, in the ideal situation, a randomized controlled treatment trial eliminates all sources of bias that would prevent attributing differences in outcomes between the compared groups to anything other than the treatment itself, isolating the effect of the treatment. All right. That's what you really want. All right. That right there is the gold standard. But even in that case, even if you have a randomized controlled trial, it's still just one. All right. There's something even on top of that, that after you get your randomized controlled trial, there's something else that you would like to have. Let me scroll all the way down. What you want here, evidence-based medicine requires knowledge of how to analyze carefully the results of clinical trials. All right, so let's recap before we talk about this meta-analysis concept that it's about to get into. All right, so at the lowest tier of evidence, you have the case study, which is essentially a story of something happening to one patient one time, right? And obviously, you can't extrapolate from one time with one patient to this is what we should do for everybody, right? But you can use it to give colloquial advice here and there to other practitioners. Happens all the time. You eat the meat, you spit out the bones, right? But you can't create, policies and protocols off a single case study. Same with the case series, right? If you've got, one thing happening in, let's say, 10 patients, right? 10 is still a rather small sample size, right? And not only is it a small sample size, but it's just something that you're observing happening, quote unquote, in the field, I guess, in the course of practice. It's not in the setting of a randomized controlled trial where you're seeing this, right? So there's all sorts of potential variables that are at play in that case. But if I'm seeing something happening in 10 patients, you know, that is worthy of further investigation. That to me is the value of a case series. Lets other people know, hey, there's something here worthy of your time to investigate, right? And you move up to the cohort studies, which is where you're actually trying to isolate variables. You're actually trying to isolate variables and causes and look at the effectiveness of treatments. That's why you have your test group and you have your control group that you're comparing the test group to see, okay, is there any significant difference when I administer this treatment versus when I don't? Um, the example that's given in the textbook here has to do with how much air you deliver per breath on a ventilator in patients that are undergoing, like a ARDS process. And that's getting a little bit technical. I'd have to explain a lot to even make that sentence make sense to people that aren't already respiratory therapists. So just, bear with me on that. But, it's only when you start getting into these cohort studies where you're actually starting to isolate for variables and you're actually trying to test for causes, and the randomized controlled trial is the gold standard because you're removing patient and practitioner bias from the equation. And ideally, you would have people do a whole bunch of randomized controlled trials. Um, and then you would do a meta-analysis of a clinical issue. All right. Let's see here. Other tools of evidence-based medicine include, this is what it is, systematically reviewing the available literature, a meta-analysis of the literature, right? So a meta-analysis of a clinical issue identifies, analyzes, and summarizes the body of literature about this topic by assessing the quality of the available evidence and giving greater weight to better designed, more rigorous studies. Sometimes meta-analyses pool the actual data from different trials together when pooling is scientifically and statistically permissible. And that's what we're going to be looking at today. The American College of Pediatrics, the ACPs, has done a meta-analysis on this issue, and I'd like to hear them weigh in. Now, why do I choose pediatrics? Because of the fact that with, and I'll explain a bit more about this later, but the issue with transgenderism, with gender affirming care, when you're getting into like hormone replacement there, especially with hormone replacement therapy, is you got to start young. Like, if your goal is to suppress the expression of sexual phenotypes and sexual dimorphism, you have to start early, because if you begin that process as an adult after puberty is already finished and set in stone, there's not too much you can do. Short of amputation, there's not too much you can do. So it makes sense to me why, people are always talking about, making a big deal about, oh, they're, trying to get to the children and all that. And I'm like, well, with this issue, it's the only way to do it right. I'm not trying to defend it. I'm just saying it makes perfect sense to me. Why? Because if you're trying to suppress, the sex organs, you should probably get ahead of the puberty game. And to do that, you got to start young. You got to start young. There's no real way around it. All right. So that brings me to the next question, the first big question. Let me check my time here. Doing on time, 15 minutes. Good, good, good. Question: is sex biological or mental? Is it biological or mental? That's a question that we do actually need to talk about, because believing that sex is purely biological is one of the bedrock philosophical tenets you have to believe before going down this road. But more specifically about that is that you have to believe that sex is really only biologically expressed in the genitals and the reproductive organs of the person. Why do I say that? Because again, hormone replacement therapy, sex reassignment surgery is really focused on genitals, getting them to not express maturely, or in more extreme cases, completely amputating them, though they be healthy and functional otherwise. Right? And so if people are going to say that the sex reassignment surgery was a success and that this male has transitioned to be a female, right, or this female has transitioned to be a male, and the only thing that really changed was you amputated perfectly healthy genitalia, then philosophically what you're saying is that those breasts that were amputated, the penis that was amputated, those things were the things that carried the masculinity, the femininity. And once those things are gone, they no longer do carry them. That's philosophically what you're saying. The truth is that sex and gender distinctions are expressed physically in many more body systems than just the reproductive system. Okay. And we'll get into I'll bring up this article in a second, but according to the American College of Pediatrics, biological sex is almost always easily identifiable at birth, if not before, based upon phenotypic expression of chromosomal complement. Very rarely in disorders of sexual development, additional testing may be required to accurately determine sex. So, to describe sex as assigned at birth is inaccurate and misleading, according to the American College of Pediatricians. I keep saying pediatrics, it's pediatricians. The American College of Pediatricians affirms the medical fact that the sex of an individual is based upon biology, not upon thoughts or feelings. The individual's sex, and this is their language, not mine, the individual's sex is encrypted in every diploid cell of the body. Since an individual's biological sex is immutable from the moment of fertilization, it cannot be changed, regardless of hormonal or surgical interventions. The so called transition is not a change of sex or even a change of sexual or gender identity, but rather only a change in sexual appearance or presentation. All right, so let me go ahead and bring up my last little photo here. Let me see here. Bring up my last photo here, and this photo comes from a different textbook. Let me put the big one down. You guys probably heard that thud. That's a big textbook. This picture comes from this one, Cardiopulmonary Anatomy and Physiology, The Essentials of Respiratory Care, the 7th edition. I I forget the pages exactly. But what we're seeing here is my area of expertise, right? The lungs. And what this chart is showing us here is the approximate lung volumes and capacities in healthy men and women 20 to 30 years of age. Okay. And as you can see, those things are different. All right. So let's look at a couple volumes here. Let me see. Let me check my time again. So all this is introductory stuff. Okay, coming up on 20 minutes. Good. Tidal volume. The amount of air inhaled and exhaled with each breath during quiet breathing. All right, so just the amount of air you move breathing normally. The adult male average value is 500 milliliters. The adult female average value, 400 to 500 milliliters. Not a substantial difference. But the next one is a not insignificant difference. The inspiratory reserve volume, the amount of air that can be forcibly inhaled beyond the tidal volume. So there's regular breathing, and then you have breathing, right? Big breath in. The adult male average value is 3,100 milliliters of air on top of the regular 500. The adult female average value is 1,900 milliliters of air on top of their 4 to 500. All right, and you can go through, I've put the chart up here. You can go through each of these and you can see the differences where the male value is always going to be, if it's different, the male value is always a little bit bigger than the female value. But we'll look here at the very bottom one, the total lung capacity. The maximum amount of air that the lungs can accommodate, right? You're adding up all your volumes. And if there are any respiratory therapists listening in your study or your exams, you should know that to make a capacity, you need 2 volumes, or at least 2 volumes. All right? Every capacity is made up of at least 2 volumes. That's a free one for the respiratory therapists in training out there. But anyway, total lung capacity. The average for the adult male, 20 to 30 years old, 6,000 milliliters of air, 6 liters of air. In females, 4,200 milliliters of air, 4.2 liters of air. All right, that is quite a difference. But here's something that I would like you to consider, all right, as it pertains to, the conversation around men and, around men competing with females in female sports. Oh, by the way, the reason I keep changing the adjustment of the screen is so I can see the timer about how much time, where I'm at time-wise in the recording of this. But something I want you to think about exercise-wise, right? During exercise, you can see a potential 20 times increase in the liters of gas moved per minute, right? So, if you were to take let me zoom back in. If you were to take the 6 liters of air for the total lung capacity, right? And the 4,200 mLs, right, in women, and that's not entirely true. Technically, I should probably be taking the vital capacity, so that way I can leave the expiratory reserve volume out of it, but I want the math to be a little bit easier, so I'm using the TLC, even though technically for this category I should be using the VC, but it's fine. It's fine. The math is easier, and the point made is still the same. Because we're talking concepts, so I'm always going to use whatever math is easier. So if you were to take this 6 liters of air and multiply it by a factor of 20, to mathematically represent strenuous exercise, very strenuous exercise, that 6 liters becomes 120 liters of air per minute that is potentially moved, right? In a male system, right? Breathing hard, you're breathing hard. The amount of air that you move in and out in a minute could be as high as 120 liters worth of air. But if you take the female's 4.2 liters of air, multiply it by that same 20 to mathematically simulate strenuous exercise, you get 84 liters of air moved a minute. That is a potential difference of 36 liters of air per minute. Now, you add on top of that the fact that men, on average, tend to have slightly more red blood cells in circulation than women do. Not by much, but, slightly. But that slight differences can matter, right? And the only way oxygen moves from the lungs to the tissues to be utilized is in the hemoglobin that's in the red blood cells, right? So the more red blood cells you have, the more efficient you can be in mobilizing oxygen from the lungs to the tissues. Obviously makes perfect sense, right? If I got 1,000 boxes to unload from a truck, it's going to go faster if I have 100 workers than if I have 10, even though it's the same amount of boxes, right? And so that is definitely a physical advantage, right? Leave the bone stuff aside, leave the muscle mass aside, leave the testosterone aside. That is a true physical difference, right? The fact that men in strenuous exercise, like a sporting event, are going to be able to move potentially 36 more liters of oxygen laced air from the outside world into their bodies, and they'll have slightly more red blood cell movers to unpack those trucks. right? Whereas ladies are going to be 36 liters a minute short of available oxygen, period, and they have slightly less red blood cells in their system to move that air. I'm not trying to make a value statement about, men are more valuable than women and all this other stuff, right? Refer back to episode 1. Genesis chapter 1 speaks against that narrative. Men and women are both equally created in the image of God. Men and women both equally share in the divine mandate to rule and subdue creation unto the glory of God, right? This is science that we're talking about, bro. Scientific, observable differences, observable distinctions between men and women. All right? And here's an olive branch. I'm not here trying to argue that men and women are different in every physical way, in every way physically to the maximum degree that we could be different. I'm not trying to argue that. My argument is that any measurable difference on average between men and women is a true distinction and should not be ignored for the sake of, for the sake of an agenda or something like that, right? Now, some would say that sex and gender are different, gender being a social construct and sex being a biological one, but I think that entire conversation is a pretty pointless distraction because whether you're a Christian like me that desires to follow Jesus, or whether you're someone that absolutely hates Jesus and Christianity and all that, where we both agree is that the mind and the body should be in agreement when it comes to gender and sex, right? The gender, the mental, should be in agreement with the physical, the sex. Both sides agree on that. The disagreement is on how to make that happen, right? I mean, that's why gender affirming techniques like hormone replacement therapy and sex reassignment surgery exist to force the body to come in line with the mind, which is one way to do it. As a Christian, I would argue that the mind needs to recognize the truth of the body on this point. Either way, though, very rarely does anyone accept the mind and the body differing, the gender and the sex different. People don't usually accept that. So I don't see the point in making a big fuss about the difference. But does this contradict my earlier point in episode 1 that the spirit animates the clay? I would say no for a few reasons. Um, One, that point in episode 1 in Genesis was about controlling the urges of the body and the clay, right? The spirit animates the clay. That's why we can do this thing called self control, right? Our clay, this physical body, has urges, has desires, but our spirit, that breath of God that, is given to us by God, is what animates the clay, is what restrains the clay, is what calls the clay upward to act and live with heaven's nobility instead of just being another creature. And secondly, male and female are categories that you can only blur or deny. You can't actually erase them. That's my point so far, and I'll about to pull up an article um, about that very thing. Let's see here. This article. Let me go ahead and pull it up. Let's see. Yep. From the American College of Pediatricians, sex is a biological trait of medical significance. Let me see how far I can come in. Yep, I like that. I like that zoom. All right, so we're going to be reading quite a bit of these guys today. So go ahead and strap in and let's get to it. All right. The abstract is kind of like the summary of the article, and then we'll get into some weeds. In the midst of society's questioning of the gender binary, the American College of Pediatricians, ACPEDS for short, is concerned that the field of medicine risks denying the reality of biological sex. Sex is a dimorphic, innate trait defined in relation to an organism's biological role in reproduction. In humans, primary sex determination occurs at fertilization and is directed by a complement of sex determining genes on the X and Y chromosomes. This genetic signature is present in every nucleated somatic cell and is not altered by drugs or surgical interventions. Sex differences arise from at least four different genetic mechanisms, in addition to the actions of sex hormones and environmental influences. Consideration of these innate differences is critical to the practice of good medicine and to the development of sound public policy for children and adults alike. The National Institutes of Health urges scientists and physicians to include sex as a biological variable in all aspects of healthcare. Although incompletely understood, the reality of sexual dimorphism and its importance to health has been documented for decades. In recent years, however, the medical field has become heavily influenced by society's questioning of the gender binary. Increasingly, physicians such as Dr. Deanna Adkins, Associate Professor of Pediatrics at Duke University School of Medicine and Director of Duke Child and Adolescent Gender Care, teach that, quote, it is counter to medical science. Let me go ahead and highlight this. It is counter to medical science to use chromosomes, hormones, internal reproductive organs, external genitalia, or secondary sex characteristics to override gender identity for purposes of classifying someone as male or female. A corollary to this ideological claim is that no one can know whether individuals are male or female unless the individuals in question make it known. Accordingly, pediatricians have been cautioned against assigning a sex to newborns for fear that this could conflict with the infant's self-declared gender identity later in childhood. These claims belie the physical, biological fact that sex is not a state of mind that one can identify into or out of at will. Pediatricians do not assign an infant sex, they announce it based upon the physical reality of the infant's body before them. This growing movement to deny the physical reality of sexual dimorphism requires a dangerous dismissal of both science and medical ethics, one that will cause severe harm to individuals and society at large if embraced. If embraced. All right, let's see here. Where do we want to go? Sex and gender are not synonyms. They talk about that. This is a topic I want to get into. Human sex is a dimorphic, innate, and immutable trait determined at fertilization. Medicine has long defined sex as a biological trait that distinguishes living things as being male or female based on the complement of sex chromosomes, the presence of distinctive reproductive organs, and unambiguous genitalia. All right, that's an important thing to note. All right, because people always make a big deal about, oh, how do you identify sex and all that stuff? It's a difficult thing to identify. The ACPEDS is saying that we've long defined sex as a biological trait that distinguishes between men and women based on these things: the complement of sex chromosomes, X's and Y's, the presence of distinctive reproductive organs, ones that are different from each other, and unambiguous genitalia. This definition is not arbitrary. So they're about to explain why that's the case, because we've heard it before where people like to act like having biological sex be determined by physical traits. People act like that's a crazy concept, that I'm defining a physical concept with physicality. This is a weird concept, but this is why. In the life sciences, I want you to catch this, all right? In the life sciences, sex is defined according to whether an organism is structured to donate or receive genetic material during the reproductive process. Organisms that donate genetic material are classified as male. Those that receive genetic material are classified as female. Human beings, as do all mammals, reproduce sexually. By definition, by definition, such a reproductive system is a binary system. It requires the cooperation of two distinct sets of reproductive organs that give rise to and facilitate the union of two distinct gametes, sperm and ovum, to conceive an offspring. The term male designates members of the species who have reproductive organs structured to produce sperm and to deliver this to female members of the species. The term female designates the members of the species who have reproductive organs structured to produce ova, receive sperm, then gestate and give birth to a conceived offspring. Defining sex according to how an organism is innately structured to participate in the reproduction of the species is a stable and universally applicable definition that allows the consistent differentiation of males from females even when individuals exhibit behaviors that are not culturally typical of males or females, right? So, in other words, what they're saying is this is a solid definition of sex that has nothing to do with gender, completely independent. And some people would say, "Aha, see, you're saying sex and gender are independent of each other." No, I'm actually saying they're interdependent. But remember my earlier point, that's a pointless distraction, right? All right. If you're an advocate of transgender ideology, if you have someone that is sexually a male but believes themselves to be a female, then you would advocate for that person to do things and receive care that mold the sex, that mold the expression of their sex into something more feminine, right? You agree with me that the gender, what's happening in the mind, should agree with the sex, what's happening physically. That's why I don't see the point. And again, I'm making the point again. That's why I don't see the point. And I'm saying, oh, they're different. Yeah, but everyone wants them to agree. So, like, what are we even talking about? Um, Primary sex determination in humans occurs at fertilization and is dependent upon the zygote's two sex chromosomes, or more specifically, upon the presence or absence of genetic material normally present on a Y chromosome. Barring genetic disorders, females contain two X chromosomes in every nucleated somatic cell, and males possess an X and a Y chromosome in every nucleated somatic cell. Interventions that alter a person's sexual appearance do not alter the person's genetic code, therefore, sex does not change. Administering sex hormones and other drugs can alter appearance and physiology to varying degrees, but these chemicals do not change biological sex. No amount of medical intervention can transition any person from one sex to the other. All right? Dumbing it down, even if you amputate a perfectly functional penis or you amputate perfectly functional breasts, every other cell in that body, right? And my fingers and my toes and my head, like every other cell in that body is stamped XY or stamped XX. The person is still a man. The person is still a woman. They're just, you know, injured now because you amputated a perfectly functional organ that had no issue, had no tumor, wasn't diseased, wasn't cancerous. You amputated a perfectly functional organ. Yeah, you damaged them, but they're still a man, they're still a woman. Disorders of sex development, DSD, are disorders, not additional sexes. Let me see where we at on time. Coming up on 40 minutes. We're coming up on 40 minutes here, people. This is about the time where brain fog tends to set in. Okay, go touch some grass. Get a drink of water, get a snack. Get up, walk around, stretch them legs. Right? You don't get bonus bucks in heaven for listening to a super long episode in one sitting. All right, do what you got to do to absorb all this properly. I'm gonna keep going. Uh, glad to see that you returned. Um, Disorders of sex development, commonly referred to as intersex conditions, are maladies in which normal sexual differentiation and function are disrupted. Some argue that DSD demonstrate the existence of more than two sexes. Why is that not the case? They're going to explain. DSD do not represent additional reproductive organs, gonads, or gametes. Because remember, earlier definition, right, they were saying that part of the thing that marks a new biological sex, a unique biological sex, is their own unique reproductive organs. Intersex people don't have uniquely new reproductive organs, they just have the usual stuff that doesn't function as it ought to. Um, Therefore, by definition, DSD do not constitute additional sexes. Human sex is a binary, not a spectrum. And people that want to, throw around memes of, well, mushrooms have over 100 and something genders or 100 and something sexes. First off, I'm not a mushroom scientist. I don't know if that's true or not. Let's assume that it is. So what? We're talking about human beings, not mushrooms, not fungi. Um, weird deviation. Weird deviation from the topic, bringing up shrooms in this conversation. But it's a meme I saw. I wanted to address it. I don't know if it's popular or not. If it's not popular, ignore it, I guess. In reality, DSD are rare congenital disorders affecting 0.02% of the population, in which either genitalia are ambiguous in appearance or an individual's sexual appearance fails to match what would be expected given the person's sex chromosomes. Reflecting the disordered nature of these conditions, all DSD are associated with impaired fertility. That's the other reason why they're not considered their own sex, because the fertility is impaired. They're not able to actually perform the function of reproduction. That's how you know it's a disorder, because you can't actually do the thing that you're supposed to be able to do. They talk about genetics being the primary driver of sex differences, though I'm not going to get into that. It's on screen. I'll scroll by slowly in case anyone wants to pause. In case anyone wants to pause and read up, perhaps. I will talk about the sex differences in neuroscience. While male and female brains are more similar than they are different, the influence of sex on the brain has been demonstrated at every level of neuroscience, from the behaving human to the ion channel. At least a decade of neuroscience research has found varying degrees of sexual dimorphism in the structure and function of the brain across the lifespan. In fact, sex differences have been identified among all major brain parameters, including but not limited to higher rates of cerebral blood flow. So this is talking about, let's see here, um, in females, what we see, higher rates of cerebral blood flow, higher percentage of gray matter tissue, and higher interhemispheric connectivity in females. In men, what we oftentimes see is compared with higher percentage of white matter, greater intrahemispheric connectivity, as well as higher glucose metabolism in limbic regions in males. Many of these differences are present in childhood, but they become more prominent with adolescence, perhaps linked to the action of sex hormones during puberty. This is my point from earlier, right? If your goal is to suppress the sexual dimorphism, if your goal is to suppress the expressed uniqueness about your sex, you got to start early before puberty puts a highlighter on those differences by bringing them into maturity. You got to do it early, right? So them going after children, while I believe it's not good, it's a logical extension of the ideology, right? Like, you know, if you can't transition them, then prevent it from ever being expressed. Like I said, I don't think that's good, but it makes sense. It makes sense. Um, More recently, sex differences in neural connectivity were also demonstrated throughout the prenatal period. These foundational brain differences appear to translate into differences in cognitive processing, visual processing, auditory processing, social skills, and more. For example, males do better with spatial processing and motor speed tasks. In contrast, females outperform males in memory and social cognition tasks. And again, all these are averages. On average, this tends to be the case. Some attribute the superiority of females in social cognition tasks solely to enculturation. However, a study of 102 neonates disproved this hypothesis. 1 day old male and female newborns were tested to see if they would exhibit a difference in the length of time spent staring at a picture of a face versus a twirling mobile. Male newborns exhibited a stronger interest in the mechanical object, whereas the female newborns showed a stronger interest in the face, which represents a social object. Since 1 day old neonates have not been enculturated, they've not been subject to culture, these results clearly demonstrate that sex differences in social behavior are, at least in part, innate. Sex chromosome and sex hormone effects also contribute to sex differences in mental illness. For example, neurodevelopmental disorders, including autism, attention deficit disorder, schizophrenia, and others, disproportionately affect males. In contrast, females have twice the lifetime rates of depression and most anxiety disorders. In the case of substance use disorders, females more rapidly advance from use to dependence, report more severe impairment in domains such as employment, social, family, and medical functioning, and suffer from higher rates of co occurring psychiatric disorders. This is explained, at least in part, by metabolic sex differences. For example, alcohol intake in women typically results in higher blood alcohol levels compared with men after the consumption of equal values. This is because the bioavailability of alcohol, due to differences in volume of distribution and gastric alcohol dehydrogenase activity, is greater in women than in men. All right. They talk a little bit about the sex differences in pharmacology, that's, drugs and medicines and stuff like that, which, again, is interesting. You guys can pause and read some of that on screen if you like. This one's interesting and a little bit more in my wheelhouse. Respiratory therapists also deal a lot with the cardiovascular system. Um, Cardiovascular diseases occur and progress differently in the two sexes because biological factors differing between the sexes have sex specific protective and harmful effects. For example, it has long been recognized that male and females have significantly different risks in regard to arrhythmias. That's abnormal electrical rhythms in the heart. Following atrial fibrillation, for example, females face a higher mortality risk, experience more symptoms, and have higher rates of recurrence following ablation. Females also experience higher rates of AFib-related stroke and greater mortality rates following stroke. However, apart from arrhythmias, females face an overall lower risk of stroke than males before menopause and a higher risk of stroke following menopause. The effect of estrogen on cardiovascular tissue contributes to this overall decreased risk in premenopausal women, but hormone replacement therapy after menopause doesn't mitigate the increased risk to women at this stage of life. Therefore, both hormonal and sex chromosome differences appear to contribute to the difference in stroke risk between males and females. Finally, and I know this to be true from experience, in both sexes, 80% of the risk of suffering an acute myocardial infarction, that's heart attack, 80% of the risk of suffering a heart attack in both sexes is accounted for by obesity, hypertension, dyslipidemia, smoking, and diabetes. However, in females, diabetes is associated with a six-fold elevated risk of coronary artery disease, as compared to only a threefold increased risk among males with diabetes. Additionally, diabetic females with coronary artery disease face a threefold increased risk of heart failure, whereas diabetic males have only a minimally elevated risk of heart failure. When matched for age, young females with CAD have worse outcomes than young males with CAD. And in the midst of an MI, a heart attack, almost half of all females do not report chest pain. This is important. I mean, this might be so important, I might make a short out of it, but in the middle of a heart attack, almost half of all women don't report chest pain. Instead, females often present with shortness of breath, fatigue, sleep disturbances, indigestion, and anxiety. Because of this, timely diagnosis of heart attacks in females is often delayed. In addition, the standard stress test has a lower specificity and sensitivity in women. The preferred diagnostic modality for coronary artery disease in females is stress echocardiography. All right, but I remember being told that multiple times, and in EMS especially, is like, hey man, like don't write off a female just because she's saying she got short of breath, a little nausea. In men, that probably is just nausea. In women, could be a heart attack. Might not be a heart attack, but it could be. Could be. Almost half of all females don't report chest pain with heart attacks. That's a real difference. And some people say it's it's chauvinism in healthcare. And kind of. I don't think it's intentional chauvinism in healthcare, and most practitioners are doing their best to retrain their mind, um, about that, and hopefully in a generation or two that won't even be a thing. People will just kind of know to consider that. But hey, that is a true difference. That is a legitimate difference right there. Let's see here. Sex differences in sports medicine. It's kind of a buzzwordy kind of topic, but it's worth glancing at. Long-term research on elite athletes has consistently shown that when matched for training, males outperform females in regard to speed and strength. Though predominantly related to hormones, these differences are also the result of sex differential gene expression. Studies have identified over 3,000 genes that are differentially expressed in male and female skeletal muscle, contributing to the difference in skeletal muscle fiber type composition, resulting in a difference between the sexes in skeletal muscle fatigue recovery and endurance testing. The findings are consistent with animal studies as well, which is wild. Force generation and relaxation are faster during fatigue in male muscle fibers as compared to females, whereas endurance is higher and recovery is quicker in female muscle fibers versus males and animals. Very interesting. Again, I'm not trying to make a narrative. I'm not trying to push a narrative of men being stronger or whatever. My narrative, if you want to call it one, is that men and women are different. We are different biologically, and those differences are real and not erasable, not fully. They're blurrable, they're smudgeable, but you can't erase the differences. You can write my name on a whiteboard in permanent marker and be able to smudge the name a little bit, but the name is there. But the name is there. All right. But most of this stuff people already know, and you're either going to accept it as true or you're going to choose to intentionally ignore it, which makes you very similar to anti-vaxxers in my book. But it is what it is. It is what it is. Um, and then they come to their conclusion here. Let's see here. I think there was something down here worth talking about. Well, maybe not. Um, oh, yeah, right here. Genetics is the reason a male who self-identifies as female remains male, and explains why giving estrogen to a male does not transform him into a female. While it's true that a male who uses estrogen after puberty will lose muscle strength and impair other aspects of his physiology, he does not alter his genetics. He remains male at the cellular level in all body systems. Catch that. In all body systems, he remains male. Because your maleness, your femaleness, is not just expressed in your reproductive genitalia. It's expressed at a cellular level in every body system. And because of that, sexual dimorphism marks almost every body system. It's not an erasable thing, it's just a smudgeable thing. Similarly, a female who self-identifies as male remains female, and giving her testosterone does not transform her into a male. In terms of genetics, she remains female at the cellular level. There is no scientific justification for allowing, let alone mandating, males access to female-specific spaces such as restrooms, homeless shelters, prisons, and the like. Similarly, just as a female doping testosterone would be prohibited from competing against other females, so too should all males be barred from competing against females. The risk for harm to females from ignoring biological sex in these scenarios is both obvious and documented. All right, so let me go ahead and show you their references. This is their sources. You can pause and you can look at the sources. You can look them up on their own to see if you believe that the American College of Pediatricians is using the data and the sources responsibly. And we'll just go ahead and scroll on down. They've got quite a lot of sources, by the way. Quite a lot. Uh, that one, I think I'm probably going to save that one for myself later, to be honest. Um, Definitely a philosophical kind of guy. But what is the importance of of making this point that sex is different? Because that's ideologically speaking, that's part of the battle. That sex doesn't matter, that these differences in sex, if they're even differences at all, ha ha ha, chuckle, chuckle, are unimportant, are insignificant, are easily masked and changed. That's not the case. And I hope that this data from from ACPs kind of opens eyes to that. Your sex is encoded into every diploid cell of the body. It marks every or um, almost every system in the body, such that even a sex reassignment surgery wouldn't be able to do it. You'd have to rewrite every cell at the genetic level and make them reproduce after that rewritten code. Um, yeah, that's not happening. That's not happening. And as you can see, 46 different sources, definitely a meta-analysis of the literature, right? Some of that stuff dealing with philosophy, others of it dealing with tests uh, and things like that. A meta-analysis, bringing together the literature, seeing what the literature says. All right. And that being said, there are quite a few, quite a few myths and slogans that have been stated uh, about this. Chief among them that I've seen being the rhetorical question: would you rather have a live son or a dead daughter? And I think it's worthy of our thought. I think it's worthy of our thought to talk about such a thing, even though it does seem to be a little crass, in my opinion. This right here is a pamphlet that the American College of Pediatricians created. Our favorite organization. The myth about suicide and gender dysphoric children. What a strong title. What a strong title that is. Let's see here. I might have to zoom in a little bit to make it easily seen for you guys. Hopefully that's good enough for you. Why would parents allow a gender-confused child to undergo these dangerous medical interventions? In many cases, the answer is untruths and emotional blackmail. Look, ACP speaks very strongly about this, and it shocked me, to be honest. Like, it really did shock me to see how strongly they speak about this. If you don't let me do this, I'll kill myself, they hear from their child. The threat of suicide is then reinforced by members of the transgender industry. Would you rather have a live son or a dead daughter? This is, and it's funny too, because I work in healthcare, and until I read this, it didn't actually hit me how true this is. In no other medical or psychological condition is a suicidal patient, let alone a child, expected and allowed to dictate treatment. So true. Even on the EMS side of things, the second you said that you were thinking about killing yourself, we had to take you. Like, we had to take you to the hospital. Like, it was out of my hands at that point. And there were even times where I would counsel people sometimes, hey man, I don't joke like that. All right? Like, don't joke like that. Don't say, oh, you're just going to kill yourself just out of your, like, if you mean that, then please tell me. But if you're just saying that out of emotion, just don't say it, because then you got to come with me. It's just, wow, that's so true, man. Suicidal patients don't dictate treatment, especially children. Children are cognitively immature to begin with. Their thinking is further impaired when suicidal. This is gross medical negligence. The suicide of anyone, especially a young person, is a tragedy, and all suicide threats should be taken seriously, obviously. However, the occurrence of completed suicide among trans-identified youth is rare and comparable to that of other at-risk groups of youth, such as those with anorexia and autism. More importantly, there is no long-term evidence that puberty blockers, cross-sex hormones, or transition surgeries prevent suicide. On the contrary, the best long-term research shows that individuals who go through medical transition kill themselves at a rate 19 times greater than the general population. So let's go ahead and get into it. And let me again look at my time. Flatly at an hour. Interesting. Good stuff. What's the scientific bottom line? Swedish child and adolescent psychiatrist Sven Roman, who is no conservative, sums up the research. There is currently no scientific support for gender-corrective treatment to reduce the risk of suicide. Psychologists Dr. Michael Bailey of Northwestern University and Dr. Ray Blanchard of the University of Toronto agree the best scientific evidence suggests that gender transition is not necessary to prevent suicide. There is no persuasive evidence that gender transition reduces gender dysphoric children's likelihood of killing themselves. But let's look at the evidence that the ACP dragged in. The suicide risk among trans-identified youth is less than or comparable to that of other at-risk groups of youth. You can see it right there, right? Trans identification increases the suicide risk by a factor of 13. Anorexia ups it by 18 to 31 times. Depression multiplies it by a factor of 20. Autism multiplies it by a factor of 8. It's right up there with some of these other mental health disorders. Children with gender dysphoria often also have depression, anorexia, autism, and other psychological conditions predisposing them to suicide. In other words, trans-identified youth don't just have the multiplication factor of 13 from their identification of being trans. They also have other complicating mental health factors that are adding their own multiplication factor to the situation. So, suicide among trans-identified youth may be due to the dysphoria. Just couldn't handle the dissonance. But also maybe not. It could stem from the other psychological conditions or a combination of both. Prevention of suicide for trans-identified, it's crazy I didn't think of this. This is also so true. The obvious things that you can miss in our culture is wild to me. But the prevention of suicide for trans-identified youth is the same as for other youth. Talk therapy and FDA-approved psychiatric medications. As reported by the American Foundation for Suicide Prevention, 90% of people who die by suicide have an underlying and potentially treatable mental health condition. One study found that 96% of U.S. adolescents who attempt suicide suffer from at least one mental illness. There is no evidence that trans-identified children who commit suicide are any different. The most up-to-date research shows the effectiveness of psychotherapy for resolving gender dysphoria in children and adolescents. The 2019 study confirms the findings of 16 studies dated 1969 to 2012, all showing that psychotherapy can be highly effective in treating underlying causes of gender incongruence, such that trans-identifying patients embrace their biological sex. Hang on, folks. I'm going to go get myself a drink really quick. All right, I'm back. I got the Sam's Club generic blue sports drink. It's pretty good, surprisingly. All right. Like I was saying, a 2019 study confirms the findings of 16 studies dated 1969 to 2012, all showing that psychotherapy can be highly effective in treating underlying causes of gender incongruence, such that trans identifying patients embrace their biological sex. And as I've stated before, that is the best outcome. Embracing their biological sex, learning to love the body that God created. Yeah, that's the best possible outcome. Puberty blockers actually cause depression and other emotional disturbances related to suicide. Discussing an experimental trial of puberty blockers in the UK, Oxford University professor Michael Biggs wrote, there was no statistically significant difference in psychosocial functioning between the group given blockers and the group given only psychological support. In addition, there is unpublished evidence that after a year on puberty blockers, children reported greater self harm and that girls experienced more behavioral and emotional problems and expressed greater dissatisfaction with their body. So, puberty blockers exacerbated gender dysphoria. Didn't help it. Cross sex hormones, testosterone for women, estrogen for men, may disrupt mental health. Women who identify as men are given enough testosterone to raise their levels 10 to 40 times above the female reference range. Past studies have documented multiple psychiatric problems with similar high doses of anabolic steroids like testosterone, such that 23% of subjects met DSM criteria for a major mood syndrome such as mania, hypomania, and major depression. 3.4 to 12% developed psychotic symptoms. Estrogen also impacts mood in complex ways. Postmenopausal women treated with estrogen often experience severe anxiety despite being placed on physiologic doses of the hormone. Men who identify as women are given supraphysiologic doses of estrogen. Theoretically, this has the potential to worsen both depression and anxiety. The most reliable research shows that in the long run, medical transition does not reduce and may even exacerbate the psychological distress that could lead to suicide. The two largest and most complete studies, one from the Netherlands and one from Sweden, which show significantly elevated rates of completed suicides among gender dysphoric individuals, both studied adults who had already transitioned to imitation of the opposite sex. These studies thus support the conclusion that transitioning does not reduce the risk of suicide and may even increase it. Transitioning merely masks the underlying psychological problems that are producing the dysphoria. It treats the symptoms rather than the disease. The symptoms rather than the disease. Um, Suicide is prone to social contagion, meaning the more it occurs and is talked about, the more likely vulnerable kids will kill themselves. One medical researcher, an epidemiologist who himself transitioned to feminized male until he detransitioned after 13 years, calls out the manipulative use of the suicide threat to bully parents and legislators. The trans industry's insistence and hype that trans identified adolescents are constantly on the brink of transphobia related suicide at rates that far exceed those of other highly relevant populations is a shameful social engineering strategy to keep societies focused preferentially on transgenderism, perhaps to cast themselves as visionary pioneers in the field. Trans activist adults and some clinicians effectively threaten suicide on behalf of the young people. They do this to socially engineer, manipulate, and intimidate non industry doctors, politicians, community leaders, and families of these adolescents. They are well aware of the emotional responses they will get with this rhetoric. And trans identified teens may be encouraged by social media and members of the transgender industry to threaten suicide if their parents resist medical transition. Psychotherapist Dr. Wallace Wong offered such advice during a presentation in Canada. So what you need is, you know what? Pull a stunt. Suicide. Every time. Then they'll give you what you need. Wong added that trans identified kids learn that. They learn it very fast. But what about studies supposedly showing that medical interventions are more effective than psychotherapy in reducing suicide attempts? Medical professionals who engage in statistical research have identified multiple problems with studies purporting to reach these conclusions. These problems include unreliable sampling, manipulated numbers, and admitted political intent. A report co-authored by the American Foundation for Suicide Prevention, which claimed that 41% of gender dysphoric individuals have attempted suicide, was based on flawed data. Along with two other studies that found a suicide attempt rate of around 40%, the Haas study used convenience sampling, which statisticians agree cannot be used to draw conclusions about the general population. The Haas authors admitted that the 41% number may have been significantly inflated because only one question, without clarifying questions, was asked about the issue. The authors further admitted the survey didn't directly explore mental health status and history, which have been identified as important risk factors for both attempted and completed suicide in the general population. In other words, the study provided no reliable information about whether suicide attempts were caused by gender dysphoria or by other mental health issues, which are extremely common among dysphoric individuals. That's a problem, too. It's like if you're trying to figure out what's causing the suicide, you got to isolate. You got to isolate for these things, man. If you're not isolating for other mental illnesses that we know have a component of suicidality attached to them, then your study is worthless. It's worthless to prove the thing that you wanted to prove. And it's also worthless to disprove the thing that I'm inclined to disprove. It's just a waste of time. The study did not determine if the claimed suicide attempts occurred before or after seeking medical transition services. That's also very important. The study found that for female respondents, being stealth or successfully passing as male did not alleviate the tendency to self-harm. The study, therefore, offered no reason to conclude that undergoing medical transition will resolve the distress that leads to suicide attempts. That's very true. It's very true. You might want to mention that. As one analyst of the study concluded, given the flawed data available to us, the leap in logic to assume the only viable choice is to medically transition or die ought to shame any provider, researcher, or journalist worth their salt. The study data, if looked at honestly, should instead spur providers to offer effective psychological health evaluation and treatment for both young people and their families in the least invasive intervention possible. The Williams Institute, which also produced and promoted the Haas report, was contracted by the state of California to use appropriate survey methods and found the trans-identified suicide attempt rate was 22%. That is comparable to rates for people with psychological illness and general LGB identification. The conclusions of a recent study, supposedly finding that surgical gender affirmation treatment reduces psychological distress, have been shown to be unsupported by the data. Dr. Mark Redneris observed that these conclusions signal an abandonment of scientific rigor and reason in favor of complicity with activist groups seeking to normalize infertility-inducing and permanently disfiguring surgeries. Clinicians are being bullied into writing a radical prescription based on fear, not on sensible conclusions from empirical data. Similar studies from the UK have been debunked for similar reasons. One widely touted study supposedly found a 48% rate of attempted suicide in young people with gender issues, but it turned out that his study was based on only 27 patients. And psychologist Dr. James Cantor found that the American Academy of Pediatrics misrepresented large numbers of studies to justify its claim that medical transition is necessary to prevent suicide. But St. K, aren't trans-identified teens likely to commit suicide because of the stigma that society puts on them? Listen, man. Listen, man. The stigma that society puts on them. Stigma? Do you and I live in the same America? Really? There's a stigma. I hadn't noticed. I hadn't noticed there was one. I'm not saying that there didn't used to be one, but I'm saying now, currently, there is not one. There's not one, bro. Like people like me that are Christian and are taking the stance that I take. We're the ones that get laughed out of the room. We're the ones that get looked at as the problems in society. No, there's not a stigma. I have a stigma. I face a stigma, right? But on, national terms, like, nah, man. What's stigma? Not in pop culture, that's for sure. Um, research does not support that claim, to say it lightly. A 2014 Australian study reported that a leading reason for suicide among LGBTI individuals was stress from romantic partners rather than societal rejection. Now that's tough. That's tough. That the source of the stress in many LGBTI individuals that leads them to suicide or suicide contemplation is the stress from a relationship that God told them not to pursue. That God in His Word said is not going to be good for you. I don't think I really need to say anything more than that. A 2014 study by Hotson Buehler et al. Claimed an average life expectancy reduction of 12 years for sexual minorities living in areas with suspected prominent anti-gay sentiment. But this study was so thoroughly debunked by the scientific community that the medical journal eventually retracted it. Reanalysis confirmed that the original finding was erroneous, and the authors wished to fully retract their original study accordingly. Nevertheless, citations of Hotson Buehler's false conclusions persist, including in Supreme Court briefs. And yeah, that sucks. That sucks. Sobering thought to know. It's a sobering thought to know that you know, knowingly debunked studies can get cited in Supreme Court briefs. And that's not my way of saying that the Supreme Court is untrustworthy. I'm just lamenting the damage and the far-reaching influence of lies. Not even lies, just misinformation. An exhaustive review of all the research on this topic by psychiatrist Dr. Paul McHugh and epidemiologist Dr. Lawrence Meyer reached this conclusion. It is impossible to prove through these studies that stigma leads to poor mental health, as opposed to, for example, poor mental health leading people to report higher levels of stigma, or a third factor being responsible for both mental health and higher levels of stigma. And I just had a conversation like this with a brother from church, right? With a church brother of mine, right? Where, he's saying that, no one in the church, talks to him and all this other stuff. No one in the. And my first question to him was, all right, boss, when's the last time you've checked in on anybody from the church? You know, if we're going to, you're saying that you're pulling away because of the lack of interaction. But isn't it I mean, I'm just saying, have you considered the idea that you pulling away is what caused the lack of interaction, not the other way around? Do you have a way to determine one from the other? Or are we just assuming? Are we just assuming the worst? Interesting thought. But even without these studies, the argument that stigma drives trans-identified youth to suicide simply doesn't make sense. Epidemiologist Hashi Horvath points out that the suicide rates for such adolescents were significantly lower in 1950. Quote, when gender roles, sex-specific dress codes, laws regulating sexuality, and other aspects of social control were much more rigidly enforced, unquote, than they are now. So, the question, if social rejection didn't cause suicide then, why would a much diminished level of social rejection cause suicide now? It doesn't make sense on its own. According to the ACPEDS, State law should encourage the use of psychotherapy to help young people explore and resolve the underlying causes of the psychological rejection of their body and avoid a lifetime of expensive, radical, painful, sterilizing, dangerous, and potentially deadly interventions. What do they mean by that? We'll talk about that in a second. But for now, let me just kind of scroll through their citations. Let me just kind of scroll through their citations here. But with this knowledge, armed with this knowledge, I would advise Christians that are confronted with this hypothetical, would you prefer a living son or a dead daughter, to expose this for, to expose this for the emotional blackmail that it is, you know? Kindly but firmly let the person know that there is no evidence-based medicine that suggests gender-affirming therapy helps this problem. You can cite the American College of Pediatricians if you need an easy to remember organization. Remind them that there's already therapy for suicidal patients. Talk therapy with a licensed psychologist is proven to be effective, and everyone's got access to that as much as your insurance will allow. But that is a conversation for another episode. Um, and you can also, bounce past the ball back into their court. Ask them if they have any evidence-based medicine, to suggest that gender-affirming therapy of any kind helps in the long run. And obviously you're going to have to calmly push back against the idea and the notion that evidence-based disagreement is the same as hate or stigmatization. Because people sadly will try to make that argument a thing. Let's see here, hour 22, a little less because I got to cut out that silent section when I walked away to get a drink. We might be doing all right. But here's another article from the ACPEDS. Mental health in adolescence with incongruence of gender identity and biological sex. This is the abstract for this article. Adolescents who have a gender identity not congruent with their biological sex have an increased incidence of mental health issues, including depression and suicidal ideation. Both before and after gender affirming therapy, adolescents who have gender identity incongruence are at higher risk for psychopathology than their peers who identify with their biological sex. Previous adverse childhood experiences may play a major role in that psychopathology and needs to be explored in helping these patients. There are no long-term studies demonstrating benefits nor studies evaluating risks associated with the medical and surgical interventions provided to these adolescents. There is no long-term evidence that mental health concerns are decreased or alleviated after gender-affirming therapy. Many individuals who have been treated with gender-affirming therapy later regret those interventions and seek to align their gender identity with their sex. Because of the risks of social, medical, and surgical interventions, many European countries are now cautioning against these interventions while encouraging mental health therapy. All right, so let me go ahead and scroll down. We're going to bounce around in a disorderly fashion with this one. Just because I think that would surprisingly be a bit more helpful. Let's see. Gender transition efforts. This is where I want to start with this one. All right. There are 3 interventions used by transgender therapists that must be examined: social affirmation, also known as social transition; hormonal intervention with use of puberty blockers, followed by cross-sex hormones; and surgical procedures. All right. Social transition. Social transition involves a change in name, pronoun use, hairstyle, and clothing to more closely match the child's perceived sexual identity, which is incongruent with their biological sex. There is conflicting research regarding possible mental health benefits to social transitioning of children with gender dysphoria. One of the earliest studies matched 73 transgender children between 3 and 12 years with 73 gender-matched community controls that included 49 siblings of the transgender children. The researchers found parental reports of depression were similar in each group, but there were slight increases in anxiety in the transgender children. However, this study did not provide evidence that social transitioning improved psychological well being. Psychological functioning assessed via parental reports on 54 children between 5 and 11 years of age who were evaluated at the Hamburg Gender Identity Service in Germany found that peer problems and worse family functioning were significantly associated with impaired psychological function, whilst the degree of social transition did not significantly predict the outcome. Therefore, claims that gender affirmation through transitioning socially is beneficial for children with gender dysphoria could not be supported with the present results. Now, maybe there's some results in the future that might, but right now, that's not what it says. The study by Wong et al. Of 226 gender variant children who had socially transitioned compared to those who had not transitioned concurred with the authors, stating there was little evidence that psychosocial well being varied in relation to gender transition status. In addition, social transitioning leads to persistence of gender dysphoria. A study of 127 adolescents who were diagnosed before age 12 with gender dysphoria in Amsterdam, the Netherlands. Also, keep in mind about how early these kids are being diagnosed with gender dysphoria. I'm not on the bandwagon of these kids are just making it up. Like, I'm not on that bandwagon. All right. Some probably are exacerbating and exaggerating, but no way they're all faking. No way. All right. There's a real mental health thing going on here. And these are people made in the image of God that need freedom. Okay. But before we can even talk freedom, we got to honestly talk about the data. Remember, that's what this episode is. But to the Christian that, looks at an episode like this as just a big fat finger to the camera, I told you so. It's not what this is. This is about trying to properly understand something that is very destructive to those who suffer from it. And then trying to figure out a game plan to tackle this thing. All right, that's like I said. I try to go for a different kind of rhetoric and tone here on Foreign Saints. A study of 127 adolescents who were diagnosed before age 12 with gender dysphoria in Amsterdam, the Netherlands, found that those who experienced affirmation of their cross-gender identification were more likely to persist in that incongruent identification. All 4 children who socially transitioned persisted in their cross-sex identification, while only 35% of the 123 children who didn't completely socially transition persisted. Thus, Zucker states, a gender social transition in prepubertal children is a form of psychosocial treatment that aims to reduce gender dysphoria, but with the likely consequence of subsequent biomedical treatments as well. Cass agreed in her review of gender services for the National Health Services and stated social transition is an active intervention because it may have significant effects on the child or young person in terms of their psychological functioning. Further, when one considers brain development of the young child with its neuroplasticity, each thought, behavior, and experience affect the person's brain. Or is it miss my place here? Affect the brain's microstructure and function. Social transition can then confirm to a child a new identity. Importantly, the child will have difficulty later questioning the new identity since parents and teachers have confirmed it. All right, something to consider with that, by the way, is that it's exactly what Paul tells us. It's an example of that. Romans 6:16. Do you not know that if you present yourselves to anyone as obedient slaves, you are slaves of the one whom you obey, either of sin, which leads to death, or of obedience, which leads to righteousness? Right? You become a slave to what you freely choose to give yourself to. But thanks be to God that you who were once slaves of sin, because you freely gave yourself to it, right? have become obedient from the heart to the standard of teaching to which you were committed, and having been set free from sin, have become slaves of righteousness. I'm speaking in human terms because of your natural limitations. All right, that to me is kind of sort of what this sounds like. You know, um, you're reinforcing this new identity to this child, to this person that is repeatedly giving themselves over to this philosophy. They will be swallowed by it, given enough time. So that's tough. Just like anyone, be swallowed up in anything if you give yourself to it enough. That's the beautiful thing, right? Give yourself over to Jesus enough, you get swallowed up, you get immersed in Him, things begin to change. But that's next episode, not this episode. Um, this one's interesting: pubertal suppression. So the hormone replacement stuff. Let's see how we doing on time. So this is important information. Doing good on time. In an attempt to examine the benefit of pubertal suppression during adolescence with mental health outcomes as adults, Turbin et al. Utilized a cross-sectional survey of, count 'em, 20,619 transgender adults between the ages of 18 to 36. In their sample, 16.9% of the participants reported they had desired pubertal suppression as an adolescent, with 2.5% receiving such treatment. The authors found those who received treatment with pubertal suppression had lower odds of lifetime suicidal ideation. Hey, sounds like a plus for hormone replacement therapy, doesn't it? However, in a published comment linked to that article, Field and Trumbull pointed out the exceedingly high rates in both groups of suicide ideation, 75% and 90%, and suicide attempts, 42% and 51%. The relatively brief follow-up period, in other words, they didn't follow up with these people that long to see, and the doubled rate of serious suicide attempts, 45.5% versus 22.8%, that required inpatient care in the pubertal suppression treatment group during the year preceding data collection, contribute to the serious concerns surrounding the use of pubertal suppressing drugs. Another letter to the editor noted that the Turbin survey assumed puberty blockers were available in the US earlier than they actually were. Most seriously, Turbin et al. Barely acknowledged the fact that adolescents with severe psychological problems would have been less eligible for drug treatment, which confounds the association between treatment and suicidal ideation. This undermines the article's recommendation to make treatment available for all transgender adolescents who request it. Then you got the Florida Agency for Healthcare Administration that requested McMaster University Department of Health research methods to provide an analysis of gender-affirming therapies. So they literally asked for a meta-analysis. Two researchers initially found 61 systematic reviews, because remember, a meta-analysis, you're trying to do an analysis of the available literature, trying to find high-quality literature, high-quality uh, tests and things to build a conclusion off of. But of the 61, they only utilized 14 for their intense analysis. Why? Because of difficulties. They found no study comparing outcomes between those using and not using puberty blockers, so they stated it's unknown whether people with gender dysphoria who use puberty blockers experience more improvement in gender dysphoria, depression, anxiety, and quality of life than those with gender dysphoria who don't use them. There's very low certainty about the effects of puberty blockers on suicidal ideation. The researchers made similar statements regarding cross-sex hormone therapy and surgical interventions. This conclusion was further emphasized by a systematic review of studies on the use of puberty blockers in children with gender dysphoria by the National Health Services in the United Kingdom, noted the low certainty of the outcomes of the studies and could find no evidence that the use of puberty blockers improved the mental health of patients suffering from gender dysphoria. All right, the Council for Choices in Healthcare in Finland reviewed research on gender dysphoria treatment. Do you get the sense like this is why I liked to use the ACP stuff, because they're quoting the world. They're just quoting the world, man. Um, For hormonal suppression, the report stated, in cases of children and adolescents, ethical issues are concerned with the natural process of adolescent identity development and the possibility that medical interventions may interfere with this process. It's been suggested that hormone therapy alters the course of gender identity development. It may consolidate a gender identity that would have otherwise changed in some of the treated adolescents. The reliability of the existing studies with no control groups is highly uncertain. And because of this uncertainty, no decisions should be made that can permanently alter a still maturing minor's mental and physical development. It's not known how the hormonal suppression of puberty affects young people's judgment and decision making. All right, so, and there's all sorts of stuff I could you know, you can go into all sorts of things. Like this, the 2021 comprehensive data review of all 3,754 trans identified adolescents in U.S. military families over 8.5 years showed that cross sex hormone treatment leads to increased use of mental health services, not decreased, and psychiatric medications, and increased suicidal ideation and attempted suicide. When transgender identifying adolescents who were using gender affirming pharmaceuticals, 963 of them, were evaluated separately, their use of mental health care services did not change, but their use of psychotropic medications did increase. Well, that's not what we want to happen now, is it? Let's see here. A longitudinal study from Denmark that included all individuals who had accessed the three national centers for gender care and compared them with 38,120 controls. There we go. We have controls now, and a lot more controls than the trans that you're testing. We like that. We like that. So what did they find? They found that the odds ratio for mental health disorders was more than 5 times higher in transgendered persons compared to controls at baseline. The risk for mental and behavioral disorders in transgender persons increased rapidly during the first year after the index date, followed by a decreasing trend. But the odds ratio remained elevated throughout follow up, especially in transgender persons assigned male at birth. Upon presentation to the centers, at least 24% of transgender identifying individuals had been prescribed psychopharmacological treatment, compared with 4 to 6% of controls. Although the proportion of transgender identifying individuals with a psychiatric diagnosis decreased slightly after the first year of treatment, the rates of psychopharmacological treatment increased and remained elevated throughout the treatment period, so that 30.5% to 39.5% of individuals were receiving treatment after 8 years, compared to 8 to 14% of controls. Gender affirming hormonal therapy was prescribed to 2,089 individuals, and there was no significant decrease in mental health concerns after treatment. The study had limited ability to evaluate the effects of gender affirming surgical interventions. All right, and like I said, there's even more that could be said on that. Mm. And lastly, sex reassignment surgery. A population based cohort study between 1973 and 2003 from Sweden matched each of 324 patients who underwent sex reassignment surgery, 191 male to female, 133 female to male, with 10 controls. Wish we could add more controls, but at least we have some, I guess. The overall mortality for sex reassigned person was higher during follow up than for controls of the same birth sex, particularly death from suicide. Sex reassigned persons also had an increased risk for suicide attempts in psychiatric inpatient care. It is extremely important to note that on the Kaplan-Meier survival curve, the mortality of transsexual persons started to significantly diverge from the controls after 10 years of follow-up, increasing substantially by 15 years after surgical reassignment. At 30 years of follow-up, the suicide rate was 19 times that of age-matched controls. The authors of this study stated, "Our findings suggest that sex reassignment, although alleviating gender dysphoria, may not suffice as treatment for transsexualism and should inspire improved psychiatric and somatic care after sex reassignment for this patient group." Hmm. And it doesn't really surprise me that there would be a window of time where, like, it seems like it works because you got what you wanted, right? Like, you successfully suppressed the sex that you actually are, so that you don't have to look at the thing that you hate. But it's not really gone, so you still have to deal with that truth eventually. So again, I'm not terribly surprised at that. And then on top of that, if the person in question um did have other mental health concerns at the time, um or just in life that they were struggling with, and all you did was amputate some reproductive bits, um yeah, you never actually dealt with any of his other mental health issues. So yeah, like that makes a lot of sense to me. That makes a lot of sense to me, sadly. Let me jump over to these notes real quick. Talking about, let me see here, talking about some things with the sex reassignment surgery. I wanted to go a bit deeper on that. So the two different sex reassignment surgeries that you have, the metoidioplasty, I think I'm saying that right, and the vaginoplasty. The metoidioplasty, a surgical procedure, I'm just reading from my own notes right now, a surgical procedure that involves constructing a small pseudopenis out of an enlarged clitoris. And sorry for the language, I'm just trying to be accurate. When, let's see here, you have possible complications from this procedure. Urethral stricture, where scar tissue blocks the urine flow. That can happen in 2 to 3% of these surgeries. You can have a urethral fistula, a hole in the urethra causing urine leakage in 7 to 15% of surgeries. But smoking, interestingly enough, can increase the risk of these complications by up to 40%, which is tough because, in the LGBT community, there is definitely a lot of substance use, um, at a rate higher than the rest of the population. Hang on real quick. Hang on real quick, people. Man, these allergies are getting to me, but we're coming right to the end here, folks. Right to the end. Now, the other one you've got is the vaginoplasty. Whew, major surgery that entails amputating the penis and using the penile tissue to create a pseudo vagina. You gotta like reinvert things. And to be honest, as we get into this, it does not at all seem very good. It does not at all seem very. I'm not even sure if I can show some of these images on YouTube, to be perfectly honest. Yeah, I'm already probably pushing YouTube with this subject matter, so I won't show it. But you can put the word vaginoplasty into the Google search images, and you can take a look and see if that doesn't seem like mutilation to you. Um, the procedure comes with a high complication rate, as you might imagine. A long recovery time, and requires lifelong dilation of the surgical site to prevent the wound from closing. Man, dilation, the physical insertion of a dilator to maintain the depth of the cavity, can cause discomfort and pain and must be performed 3 times a day in the immediate post-operative period, which can take up to 2 to 2.5 hours a day, 3 times a day. As the patient recovers, dilation gradually tapers off, but the surgical site needs to be dilated once a week for life after that. Because obviously it's a wound, it's a mutilation, and your body is doing its best to try to heal the dang thing, but You're literally shoving something into an open wound uh, to keep the wound open. Like, I know it's surgery, but it's like you're amputating a perfectly good male organ and inverting it to create something that doesn't even have like the proper nerve endings to work like a vagina. Sad, man. It's just it breaks my heart to know that people are like you're suffering so much mentally that you're willing to put yourself through this. Right? This is why I feel like it's weird. I feel like it's weird whenever like conservatives and stuff make fun of, not to say that all conservatives do, but some do. I feel like it's weird whenever conservatives just kind of poke fun at the entire population of trans people sometimes, or talk in a unnecessarily crass way. Like if you're willing to do this to alleviate mental distress, that mental distress must be high. That mental distress must be high. And part of what I'm doing about it is this series. The series is definitely driven by compassion, so much more than a desire to be right. All right, being right is a distant second to the joy of compassion, bro. Like, man. Um, Vaginal stricture, neovaginal stenosis, is a common complication following penile and virgin vaginoplasty. A 2021 study found that almost 15% of males who underwent vaginoplasty at Mount Sinai Hospital had to have one or more revisional surgeries due to neovaginal stenosis. 73.5% of whom were unable to adhere to the post-op dilation schedule. And it doesn't surprise me because of a saying that I was taught. Comfort creates compliance. Comfort leads to compliance. And discomfort tends to lead to non-compliance. In other words, if you need your patient to do something, if you want your patient to do something, do your best to make it comfortable, or at least as, you know, you know, uh, to mitigate the pain as much as you possibly can and mitigate discomfort as much as you possibly can, because we're humans, we're creatures that are addicted to comfort for better and for worse. Um, and so you want to try to remember that or take advantage of that in medicine. Comfort leads to compliance. But this vaginoplasty, man, this is anything but comfortable. Anything but comfortable. I'm not surprised that so many people that were uncomfortable were not compliant. But the problem is, man, you have an open wound, man. Uh, I mean, they wouldn't call it an open wound, but you mutilated the body. Yeah, yeah, that's tough. That's sad. Um, let's see here. Vaginoplasty revision surgery is more difficult due to scar tissue, which also makes dilation post-revision surgery more challenging and painful. Neovaginal stenosis is just one of many complications that can arise after a vaginoplasty. A 2018 review of the data on vaginoplasty complications provides a long list of all the possible complications, ranging from minor aesthetic issues to severe complications such as rectal injuries and serious urinary dysfunction. And like none of this stuff is like, we know this stuff. Again, Romans 1 being proven true again. Though they know that the consequences are bad and inevitable, they still send people down this road. We still send people down this road. Absolutely wild to me. Absolutely wild. Let's see. I think that's it as far as that goes. Um, which is probably more than enough for a lot of you that have listened this long, to be honest. Um, what I will say is we come here towards the end, right? Um, just a short little recap. Gender-affirming therapy of all kinds has no good evidence-based medicine to support its continued use. Rather, the evidence that does exist seems to suggest against this line of treatment for gender dysphoria. The weight of most appeals for this comes down to emotionally manipulative slogans and people not knowing the state of the research. And from our previous episode in this series, Romans 1 proves itself to be true. There is an unavoidable penalty for wandering from the truth, being received in people's bodies across the globe. But next time, for episode 4, I plan to do my best to better empathize, and to help us as Christians better empathize with the struggle and trauma of identity dysphoria using the scripture. I did not say criticize, I said empathize, and I did not use the term gender dysphoria, but identity dysphoria on purpose. All right? But until next time, I'm Saint K. This has been the Foreign Saints podcast. Go in peace.